If you look at the cardiovascular risks, there have been lots of analysis, meta-analysis, as well as pooled data from very old either randomized trials, cohort studies, and case control studies. And unfortunately, there probably will not be any major, large prospective trial on the non-selective NSAIDs because these drugs have really been on the market for many years already. So this is taken from the HSA guideline, which I think most of you would have received in the last 2 months or so. And I think the recommendation now, which most people would generally agree with, is that the older NSAIDs are associated with a small and increased cardiovascular risk. And we're talking about risks in terms of myocardial infarction and stroke. And of all the NSAIDs, you'll find that naproxen from most of the meta-analysis appears to have the lowest cardiovascular risk. And the risks for diclofenac, Indocid, and ibuprofen are unfavorable compared to placebo. And generally, again, it's a question of how long the patients have been on these traditional NSAIDs. The longer the time, the higher the risk, and the longer the time from the NSAID discontinuation, the lower the risk of an association with cardiovascular events. And generally, the same holds true as for COX-2 inhibitors, mainly that NSAIDs should not be prescribed in patients for pain relief, especially if they have recently undergone vascular surgery in terms of either a CABG or revascularization procedures. So these are some of the common NSAID-induced reactions that you probably see in clinical practice. The more common one would probably be the center one, which are the GI side effects. With long-term use, you can end up with chronic kidney disease in the form of analgesic nephropathy. And this is something which you probably see and hear quite a little bit of, which is NSAID-induced eye swelling. And this is not an allergic reaction, but what we sometimes call a pseudo-allergic reaction or an idiosyncratic reaction. It's a genetically predisposed condition where some individuals, after taking NSAIDs, even if it's the first dose, develop periorbital swelling. And in some people who are really very sensitive, they may even develop an anaphylactic type of reaction or severe bronchospasm in the form of what appears to be like aspirin-induced asthma. So in that kind of situation, it's when selective COX-2 inhibitors sometimes has a role, where it can be used not just as pain relief, but also in people who have developed hypersensitivity reactions to the non-selective NSAIDs. And generally speaking, what we do, at least in a specialized kind of allergy clinic setting, is for patients who develop periorbital swelling or idiosyncratic reactions to multiple types of NSAIDs, what we do is to bring them in for a drug provocation test to either celecoxib or etoricoxib and see whether they can tolerate this or not in a controlled kind of drug provocation manner. So the selective COX-2 inhibitors, apart from having that advantage, have other advantages in the sense that there is a relatively lower risk of gastroduodenal side effects. But please note that there is a lower risk, but that is not equal to no risk. There is still a risk of patients sometimes developing GI side effects, be it perforations, ulcers, or bleeds, with the selective COX-2 inhibitors, although the risk is generally lower than the conventional NSAIDs. Now, the other thing that most people are sometimes unaware of is the nephrotoxicity of the selective COX-2 inhibitors. It's really no different from the traditional NSAIDs, in the sense that if you give someone a dose of Arcoxia, say, which is either 90 milligrams or 120 milligrams, in someone who doesn't have very good underlying renal reserve, the patients can actually develop acute renal insufficiency after just about 3 or 5 days of Arcoxia 90 to 120 milligrams dose. So I would be very careful giving that kind of dosage of that kind of medication, especially in the elderly or people who have a predisposition to developing renal disease, for example, people who have poorly controlled hypertension or chronic renal insufficiency. In terms of the cardiovascular risks, I don't think we need to go through too much of that again, except to say that a lot of the studies in the last 2 to 3 years, the prospective trials on etoricoxib as well as celecoxib have shown that the long-term use in excess of 18 months is indeed associated with the risk of myocardial as well as cerebral infarct. And these practice tips have been lifted basically from the guidelines, and there are also recommendations worldwide by most of the rheumatological associations as well as the pharmaceutical agencies that caution should be prescribed when there are risk factors including hypertension, hyperlipidemia, diabetes mellitus, and risk factors of vascular disease. And that in any patient where you would want to consider prescribing either celecoxib or etoricoxib, especially where there is existing ischemic heart disease, stroke, or congestive cardiac failure. Really, the risks versus the benefits have to be explained to the patient. Although it would be really pretty understandable that most of patients who have really pretty advanced OA knees are in a fair amount of pain most of the time. And these medicines have been shown to be effective in the relief of pain. One of the older drugs that has been on the market for many years, but unfortunately kind of got lost along the way when Vioxx, rofecoxib, as well as Acoxia and the other new COX-2s came about, is this drug called meloxicam, otherwise known as Mobic. And looking at some of the old studies, there is grade A and level 1 level of evidence to show that meloxicam can indeed be useful in the short-term relief of pain from OA knees. And in terms of its GI tolerability, it is better than the traditional non-selective NSAIDs. Nimesulide is a drug which has been in the market in Singapore for the last 5 years or so, but has been suspended by HSA in June 2007 following the increasing studies worldwide, which from pharmacovigilance studies appeared to show that there was a higher risk of patients developing toxicities. But really, this drug is quite effective, especially in people who have NSAID-induced either angioedema or GI side effects, and most patients are able to tolerate it because nimesulide basically works like meloxicam. What about tramadol? Now, tramadol is one of those drugs which is like in between. It has both opioid agonist as well as antagonist effects. And tramadol is a good alternative to NSAIDs for pain relief, especially in physical functioning and where the risk of adverse effects from NSAIDs outweigh the benefits. But having said that, because of the nature of tramadol tends to, well, in the clinical situation, produce opioid-like side effects, as in sedation, nausea, giddiness, vomiting, and things like that. So it would be important to just keep those at the back of the mind because most patients would probably not want to take these medicines despite its safety profile if they are already developing a lot of side effects from it. But if you look at the recommendations by the American College of Rheumatology and the American Pain Society, tramadol has been shown to be effective in patients who have had an inadequate response to traditional paracetamol, the COX-2 inhibitors, or the NSAIDs. And whether it's in the short-acting form or in the extended-release form, they have been found to be effective in the relief of pain. Just a word about oral corticosteroids. This is something which we do see a little bit of in the rheumatology clinic now and again. Patients who have had osteoarthritis of the knees and who have been given systemic corticosteroids for pain relief, either because they have a contraindication to the traditional NSAIDs or contraindication to the traditional COX-2 inhibitors. Just to bear in mind that oral corticosteroids really is not indicated for the management of OA knees. Basically because OA is not like RA, which is a systemic inflammatory disease, and really the risks and the side effects associated with oral steroids far outweigh the benefits in using it in patients who basically only have symptomatic OA knees. So the take-home message would be that pharmacological treatment, like in most chronic medical diseases, should just be an adjunct to the other treatment modalities which my subsequent speakers will elaborate on later on. And pharmacological treatment should really be for the relief of pain and only acutely, and should, as far as possible, not be used in the long-term management of pain for patients with OA knees. Again, the bottom line is that the lowest dose and the minimum duration should be used, except for paracetamol, which is really one of the safer drugs. But having said that, bear in mind to remind the patients that for paracetamol to be effective, it really has to be taken up to 3 to 4 times a day in order to improve symptom function as well as to improve pain relief. Thank you very much.